Big news! Multiple generic entries for Farxiga, dapagliflozin, are expected this April before others in the class. Another reason to prescribe Farxiga today. View efficacy and safety information at farxiga-hcp.com.
Farxiga.
Big news, cardio nerds! AHA Scientific Sessions 2025 is now 4 full days. Get more late-breaking science, immersive learning, and meaningful connections. Don't miss core cardiology programming, 21 education communities, and guideline-focused sessions. November 7th through 10th in New Orleans. Register now at scientificsessions.org.
Worldwide, cardiovascular disease affects the lives of hundreds of millions. Dedicated cardio nerds everywhere are working hard to fight this global epidemic. These are their stories.
Hey cardio nerds, this is Jeanne de Lavallaz. I'm a second-year EP fellow at the University of Michigan and the fellow represented at Heart Rhythm TV. And I'm here today with Ramy Doss, who is a third-year cardiology fellow at Nazareth Hospital in Philadelphia and a proud member of Cardio Nerd EP Committee. We are excited to welcome today our expert faculty, Dr. Varun Sundaram and Dr. Sanjeev Saksena, for a discussion on the recent Transform AF trial, which was presented as a late breaker at the latest HRS Congress in San Diego. Dr. Sundaram is the Section Chief of Advanced Heart Failure at the Louis Stokes Cleveland VA Medical Center, University Hospital Harrington Heart and Vascular Institute, and Associate Professor of Medicine at Case Western Reserve University. Dr. Sundaram earned his PhD from the Imperial College London and his master's degree in clinical trials from the University of Oxford. Dr. Saksena is a professor of medicine at Rogers Robert Wood Johnson Medical School and medical director of the Electrophysiology Research Foundation. He is a past president of the North American Society of Pacing and Electrophysiology and the founding editor-in-chief of the Journal of Interventional Cardiac Electrophysiology. Welcome, Dr. Sundaram and Saksena.
Thank you, Jeanne.
Dr. Sundaram and Dr. Saksena, thank you so much for being with us. It's a great honor. Let's jump into a case from Cardio Nerds Clinic. We have Mr. Fibberman, who is a 67-year-old retired school administrator with a history of type 2 diabetes, hypertension, and elevated BMI of 35.7 kilogram per meter squared. He was recently diagnosed with a symptomatic episode of atrial fibrillation that lasted for 24 hours and required a hospital admission. He is understandably anxious about the possibility of recurrence. So before Transform AF, how did we view the role of obesity in atrial fibrillation risk, and how did that influence treatment decisions?
Thanks for the question, very clinically relevant question. So as we all know, there's extensive early epidemiological studies clearly showing a dose-response relationship between rising body mass index and risk of atrial fibrillation. And it starts around 26 of BMI is when we start seeing around 26, 27. And these are early studies showing association, but subsequent Mendelian randomization studies established a causal between obesity and atrial fibrillation. Some of the early work in this comes actually on randomized fashion comes from Dr. Prashant Sanders from Adelaide, who's done a lot of work on lifestyle modification and AF. When, like he said, early trials in 2012 or 2013, looking at lifestyle modification and weight loss and showing reduction in atrial fibrillation burden of AF and in simple severity scale. So, but these are clinical efficacy endpoints, and guidelines have recommended it, lifestyle modification in terms of management of AF. But the issue is the bridge between clinical efficacy and clinical effectiveness. As you all know, efficacy is what we see, observe in trials, and effectiveness is what you see in clinical practice. To translate the findings of weight management in clinical practice in the absence of pharmacotherapy in a long-term durable fashion requires sustained behavioral change. So that's one of the reasons why we have had issues translating clinical efficacy into effectiveness in clinical practice in terms of weight loss. So while you're able to do it in trials, you have coordinators, and by nature, patients who get enrolled in trials are quite compliant and a different, what you would call a phenotype. To really get into effective clinical practice, the behavioral part has become a big issue. And that's where the advent of GLP-1 receptor agonists comes into play, where it gives an opportunity for long-term durable management of not just obesity and other concomitant metabolic risk factors, giving us an opportunity to improve long-term outcomes or reduce the risk of subsequent AF-related events. So that's in a bridge from epidemiology to existing randomized trials and the knowledge gap.
I think that's a really good delineation of the sequence of events that has been evolving in electrophysiology. And I'll step back a little bit to cardiology. And I think the interest in the risk factors of cardiovascular disease early on identified that obesity was linked to many disease states: hypertension, coronary heart disease, hyperlipidemia. And we were talking about Al Waldo a moment ago. Al was one of the earliest people to identify that the most common link to atrial fibrillation was on the disease state was hypertension. Al and I worked together in planning the AFFIRM trial. And to our surprise, the comorbidity that was at the top of the list that you take for granted today was a surprise. We thought it would be coronary heart disease. It turned out to be hypertension. And then cardiometabolic diseases like diabetes emerged as a significant comorbid conditions. So we were beginning to start thinking about the substrate in atrial fibrillation from those disease states. But we really didn't think much more about the link there. And especially with obesity was sort of was a secondary connection to these disease states, which were expected to be the primary event. In fact, then we moved forward to the ablation era, and there was a clear interest that developed on the efficacy of ablation related to the severity of these disease states. And while we were looking at hypertension and syndromes like heart failure, suddenly BMI emerged as a player in the effectiveness of ablation. And could you do ablation in people with significantly elevated BMI? So that became the initial focus of the electrophysiology community. In parallel, there was something going on which we weren't paying a lot of attention for in EP, which was the recognition at the turn of the 21st century that the most common form of heart failure was not HFrEF, but there was a huge syndrome of HFpEF. And in HFpEF, a heart failure colleague like Dr. Sundaram identified these different phenotypes. And among those phenotypes was obesity, in addition to sleep apnea and other and renal disease, et cetera, along with hypertension and coronary disease. The link with obesity suddenly started becoming a bigger issue as we started delving into the mechanism of the HFpEF. Now, electrophysiologists are taught all the time that the symptoms of atrial fibrillation are palpitations, chest pain, dizziness, even syncope and dyspnea. And you can't tell what dyspnea is like in atrial fibrillation as its mechanism are related to the tachycardia or its cardiomyopathy, et cetera. But meanwhile, our heart failure colleagues were looking at the development of HFpEF and the mechanisms. So in those mechanisms, we suddenly realized a common role of systemic inflammation and then leading to endothelial dysfunction, vascular dysfunction, evolving into what changes into the substrate. And obesity was a player in this. So now we are seeing the merging of the heart failure understandings of HFpEF with the development of atrial fibrillation in these phenotypes. And very importantly, studies from Mayo Clinic and Prash Sanders and et cetera are now suggesting that there's occult HFpEF in these basic mechanisms in HFpEF that are at a cellular and micro and a subcellular level operate also in obesity.
Now we have a lot in common. So in heart failure and EP in this. So just to one thing, what Dr. Saksena pointed out is extremely important. And actually, to be honest, less talked in the EP environment as much as how much it should be. And in fact, the Mayo study, which he pointed out, when they exercise patients who were referred for AF ablation, and they did an exercise right heart cath, 90% of them had high left ventricular end-diastolic filling pressures. with exercise. Of course, you could argue that it's a selection bias, it's an overestimate in a referral center, but just to point out, there's a significant overlap between HFpEF and AF, and you have common precursors in terms of mechanistic underpinnings, like what Dr. Saksena.
So the take-home message is, have an AF patient with dyspnea, talk to your cardiology colleagues about disease states, look for left atrial and left ventricular dysfunction, and start thinking about hemodynamic parameters, testing them for their maximal VO2 uptake during exercise and things like that. So, and the reason for that is very important, because that's the subject of today's discussion. Treating HFpEF early or treating AF early, which we are now proposing in great measure, may prevent the cascade of development of the complications of AF, of which the most common is not stroke, it is heart failure. Heart failure is the most common complication of AF, and we focus a lot on stroke. So when we reanalyzed the AFFIRM trial, those of us who planned the AFFIRM trial were absolutely confounded by the results, and we couldn't understand why. And there were lots of analyses as to the inefficacy of anti-drugs. But the real analysis that gives the clue to what the issue is, the one done by my colleague April Slee, where she showed that the emergence of heart failure in patients with atrial fibrillation over a 3-year period is about 20%. And that is reduced by rhythm control, even if it is not very effective rhythm control. So the answer here is rhythm control may prevent the development of HFpEF, and early treatment of HFpEF prevent the development of AF.
Thank you so much, both. That was a fantastic introduction for this trial. I think we already touched on a lot of very important points that we'll get back to. And when we'll see a little bit, we'll ask you some other specific questions regarding this trial. But I would like to very briefly just dive into the trial design of this Transform AF. So the trial included adults with type 2 diabetes mellitus, atrial fibrillation, and obesity with a BMI over 30 kilo per square meter. And these patients were identified from electronic health records across 170 VA hospitals between 2000 and 2022. It's an extensive number of hospitals and very long time for follow-up. Patients had to meet rigorous criteria for active AF. The intervention was the initiation of a GLP-1 receptor agonist at diabetic dosing, and the comparator, the initiation of a DPP-IV inhibitor or sulfonylurea. And the primary composite outcome included time to first AF-related hospitalization, AF-related procedures such as cardioversion or ablation, or all-cause mortality. The median follow-up of the study was 3.1 years. Now, Dr. Saksena, I would like to ask you another brief question here. So how does this trial inform the management of the patient that Ramy just presented to us with active atrial fibrillation and type 2 diabetes? What does this trial bring that we didn't know before?
This trial actually is now moving upstream in the story of the atrial fibrillation patient. So in 2023, there was a study presented out of the Leahy Clinic looking at recurrent AF after ablation and the use of drugs to treat obesity, and showed some benefit post-ablation. Now we have moved upstream before ablation to the patient that you mentioned is now had a 24-hour episode of atrial fibrillation that we know is associated with 3 things: a high likelihood of recurrence, risk for stroke and a need for anticoagulation, and perhaps evolution in the presence of in disease states such as this patient has to persistent atrial fibrillation, which we know now quantitatively promotes heart failure. So this trial has now moved us earlier into the earlier history of that patient with atrial fibrillation who has comorbid conditions like diabetes and perhaps others, as you can see in the data. The validity of the trial, it's very hard to do huge prospective studies, and we rely now more and more on these real-world experiences of these large databases to cull out patients in sufficient number to compare, as Dr. Sundaram did, over 1,200 patients in each group. And real-world experiences are now increasingly recognized as more reflective of the experience in clinical practice than, say, a randomized trial. So I think the trial itself is valid, but we do have to remember that in this process, they culled out 97% of the patients in the database. This is only 3% of those in the database. So we should remember that these patients are very specific patients from that database. I think the median follow-up of 3 years is a very decent follow-up. The primary and endpoints that they used are markers for the need of clinical events in the life of a AF patient, which is a cardioversion or an ablation today. And all-cause mortality is being measured as to look at the overall impact on human health here. What I will say is missing is that the antiarrhythmic drug profile is missing in these patients. And that is true. It's important because most patients who get a cardioversion do get additional therapy. They don't go from cardioversion to ablation or from ablation to cardioversion again and again. They usually get antiarrhythmic drugs or rate control drugs, depending on where you are. So that's one piece that I will critique in this. The other aspect is that AF burden is not able to be measured with the availability of the covariates that are in that database. AF burden is linked now to the most important complication, which is heart failure. So in that AFFIRM analysis of Dr. Slee that I mentioned, if you were able to keep patients out of AF on serial ECGs 75% of the time, your risk of heart failure development was reduced, and that ultimately translated into cardiovascular mortality. And the other issue that I have is the method used to match the patient groups. The IPTW technique is not as robust as other matching techniques, as a propensity score matching, and certainly, as we have mentioned, it's not a randomized trial. So, and then the AF-related hospitalization component of the endpoint is we sometimes hospitalize people for cardioversion and post-cardioversion. So we pointed that out in a publication in 2010 in AFFIRM. AF patients for rhythm control have more hospitalizations because you're trying to get into rhythm control. With those caveats and the absence of the heart failure endpoint, these are things that we have to think about for future trials. But having tested that, it turns the focus to a very important piece. I look at this as, let me give you two analogies. One is coronary heart disease. Coronary bypass surgery and angioplasty have evolved as an intervention. But then the rest of the time, we try and reduce risk factors, control cholesterol, blood pressure, etc. This is the equivalent of that. Surgeons with patients with breast cancer, they have a mastectomy, but then they get a whole lot of other treatments to prevent recurrence. And the success rate of intervention plus other preventive therapies has raised the survival in breast cancer to astronomical levels that we never saw when I was a medical student. So that's the analogy for our patient for atrial fibrillation. And that's where this trial belongs.
Fantastic. Thank you so much. So now we would like to move to a couple of trial-specific questions. Ramy, do you want to go on maybe?
Yeah, thank you. That was great. Dr. Sundaram, while randomized controlled trials are lacking and maybe challenging to obtain, like Dr. Saksena highlighted, your finding could have major implications. So how do you see future guidelines incorporating GLP-1 receptor agonists for secondary prevention in AFib, especially in patients with comorbid obesity and diabetes?
Yeah, so that's a great question. And just following up with Dr. Saksena, what you mentioned, those are all absolutely valid criticisms of the study. So those are exactly the right criticisms, where we had to enrich the cohort of AF. We would have to have a high specified cohort because in electronic health records, you want to clean all the, what we would call likely garbage. So we want to be sure of who we have recruited to enrich the AF cohort. So we compromise on sensitivity of dropping, as opposed to by enriching specificity. So that's the reason for 97% of them. The opposite of what you would expect in a randomized trial, by screening to randomization, you would want to hope that you maintain sensitivity because you're naturally quite specified in randomized trials. Going to the guidelines of what you're mentioning is, we pointed out, and Dr. Saksena also pointed out about future trials in this area, and then he rightly pointed out the issues in this area. And he's given a very good historic analogy with other key aspects. So the issue being to get into class 1 level of evidence, you would absolutely need a randomized trial. The question comes, how would we do this in the space? The ethical considerations, where in the current era, to take patients with atrial fibrillation and a body mass index of greater than 30 and to randomize them to a control group with no GLP-1. And because here you're modifying a risk factor and looking at outcomes, that would mean you need a longer follow-up. So that means you are mandating that control group with BMI of greater than 30 should not be exposed to GLP-1 for a longer period of follow-up. And to not have crossovers, because some of them would say, oh, I want to go on GLP-1 during the trial, so that will get the results close to null, is quite challenging in modern day and age. The second thing is, for example, when I was talking to Novo Nordisk, so the patent is almost getting over for close to 2032. For them to embark on a new trial is just not financially something which is appealing. And also the huge ethical considerations, because you need large number of patients with long-term follow because you're modifying a risk factor. And to expose them to say that you're not going to get GLP-1, you would question that there is no uncertainty in terms of obesity to be able to randomize. So that's a clear challenge. So in that case, with increasing evidence of clinical effectiveness and maybe surrogate studies with short-term, like say mechanistic trials with short-term follow-up, where you could say you would not go on GLP-1 for, let's say, 4 to 6 months. 3 months is a blanking period. What you use in AF trials may be longer, little longer. That too, I find it quite hard. It's going to be class 2 level of evidence. And this, coupled with earlier studies on lifestyle modification and weight loss and reduction, and a long-term durability of GLP-1 coupled together, I would anticipate is a more durable way, but it's unlikely to get to class 1, but class 2. But again, this is to say there are two things they say in when it comes to evidence, right? So either you have absence of evidence, that means you don't have evidence, that is, no study has been done in let's say in a randomized fashion, or evidence of absent effect. That means you do a trial and you show there's no effect. In this, we will stay into the first category of absence of randomized evidence. And I don't see a randomized trial, a large, well-done trial in this area. So it would likely be level 2 evidence, but it should be adopted because you have level 1 indication for obesity reasons. A BMI of greater than 30 would give level 1 indication to initiate GLP-1 for obesity reasons. And that's what we as clinicians should be using it in practice, in my opinion, using that as level 1 indication and not wait for randomized evidence, because in my opinion, it's going to be very challenging to do.
Just a comment, I guess this relates to my time in the field. This discussion occurred with the development of angioplasty, coronary bypass surgery. And you know what we did was we couldn't ethically randomize patients to no angioplasty, especially in the acute coronary syndrome, right? So the issue was resolved by showing physiologic benefits, evidence of physiologic benefit. And that is hard data. It is what we would clearly talk as a surrogate endpoint, and then eventually you would do a large database or other data collection process to show a mortality benefit. And that is a pathway to class 1 guideline. And I suspect we're going to go there.
Okay, very nice, very interesting. Maybe my next question would be, so for electrophysiologists, outcome after ablation are a key concern. I'm going to maybe ask you, Dr. Sundaram, again for this question, because I believe the trial hasn't yet been published. So this is a question about subgroup analysis. You might be better placed to answer this one. So did you perform any subgroup analysis among patients who had a recent AF ablation? And if so, was there any signal suggesting that the GLP-1 receptor agonist might modify outcome in this post-ablation population?
It's a great question. So the question is around close to 15 to 16% of them had overall combination of cardioversion and ablation in the recent prior in the 12-month period, but 85% of them did not. The thing is, we didn't do a separate subgroup analysis, but what we know is a relative risk reduction in patients with AF ablation, prior history of AF ablation, where there's no heterogeneity of treatment effect. So that means what could be is, while in relative terms, it is largely the same. The absolute risk reduction is something which we will not know, because absolute risk reduction will be based on the risk of event in that group. Let's say because the risk of recurrent events is higher in the group who had ablation. That means the same 70% relative risk reduction would mean more in absolute terms because of the risk of event. That can't be quantified in a subgroup analysis, but in relative terms, the effect does hold, but in absolute terms, I suspect it's going to be higher because of the increased risk of event with the same relative risk reduction.
Okay, very interesting.
Just to add, the Leahy Clinic study, which was a multi-center study, involved Cleveland Clinic also, was done post-ablation. And it was done for SGTL, the LT2 inhibitors, not the GLP-1s, but it showed a 25% reduction in their AF composite endpoint with a 15% risk reduction at 1 year follow-up. So there are bits of data now emerging with drugs have different effects. So SGLT2s have anti-inflammatory and other effects and effects on glycemia, etc. So I think we will be seeing more of this subgroup that you're talking about.
So thank you very much. I have a question, Dr. Sundaram. The GLP-1 agonists are increasingly prescribed for weight management. While your study has focused on diabetics and those who have increased BMI, do you speculate that the AFib-related benefits could extend to the other populations as non-diabetic or lower BMI? Or do you see that weight loss and glycemic control as sole or key mediators here?
So one interesting finding, what we observed was that in the weight loss percentage, because these were diabetes management doses, not obesity management doses, was an incremental 4.5%, not as striking as what you would see for weight loss dose management. It raises the question of non-weight loss mediated effects clearly in patients, and this in patients with AF. And the subgroup analysis showed significant heterogeneity of treatment effect with increasing body mass index. So those with higher body mass index had a greater effect size. But you cannot possibly exclude a non-weight loss mediated effects in patients with AF with only incremental 4% weight loss in the group. This goes back to one of the recent trials, and not recent anymore, it's been a year, called the SELECT trial, which was published in GLP-1 for patients with high risk for cardiovascular disease, and they looked at largely cardiovascular outcomes. So the group enrolled patients with a body mass index of as low as 27. As Dr. Saksena would agree, the definition of body mass index is very vague. For Asians, it's a much lower body mass index, which has actually been described as obesity, not the 30 cutoff what we use. So in the lower group of body mass index of less than 27, up to 27 has been, and what it showed was reduction in heart failure outcomes, and especially HFpEF. So Dr. Saksena rightly pointed out earlier that there's a significant overlap between AF and HFpEF with common precursor, that is common mechanistic underpinnings. So it makes a case that at least with the current evidence that the body mass index of up to less than 27, clinical evidence. But the next thing comes is those patients with lower body mass index, that is less than 30 or less than, with evidence of visceral or epicardial adiposity by imaging, do they stand to gain? Because the body mass index is largely, it's not necessarily a biological classification. A BMI of 30, it was a clinical study classification in early days where you gave a dichotomous split. It's not truly. So in those patients with lower body mass index, with evidence of visceral or epicardial adiposity by imaging, is one group who may, but needs to be tested or studied further.
Yeah, I think your point of adiposity or being a continuous variable, I think makes very good pathophysiologic sense. And if we talk later a little bit about mechanisms, these underlying mechanisms that are common to these phenotypes of HFpEF and to AF are important underpinnings. And, for other digression, that aging is related to systemic inflammation. That's the overall belief that as you suffer more inflammatory diseases as you age, aging comes with that. Now, it all works through this, probably the somewhat similar mechanism. So yes, I think there will probably be a continuous rather than a variable rather than a dichotomous situation.
it's very equivalent in heart failure, or let's say in heart failure EP field, like saying EF less than 34 is HFrEF and 36 is not. One would benefit from ICD and 36 is not. Right. So
I have to make a comment here because I wrote that paper at 35, and it is now reemerged as some kind of, we never said that over 35 was not associated with risk or treatment benefit. And
that's
it was
a clinical implication.
If you read the original,
it's not what you imply, but that's how clinicians imply.
Yes, that's right. And I've spent 20 years trying to correct people from looking at it. EF is a continuous variable, and and the heart failure people are teaching us more and more about this. And unfortunately, in EP, we want to simplify this the complex development of heart failure. Meanwhile, we are very good at the complex electrophysiology of arrhythmias, but just to make a point, I said that was a point at which the intervention of a device did better than antiarrhythmic drugs, just like analogous to your ablation data and PAF. That I felt I had to make that point. Having designed AVID and FRM, I think it's one.
It's actually, so as you pointed out, it's a clinical trial classification, HFrEF and mildly reduced or what, but it's not a biological classification.
Actually, that paper was almost not published. And the reason was that I used to do cardiac cath in those days, and there was a lot of data showing ejection fraction having value in MI and heart failure. So when we designed AVID, I asked for that stratification. And there was questioned by the EP members as to why would you care about this? And I said, well, Masood Aflan and I have seen that the people with low EF use the ICD much more. And the statisticians were very skeptical. And when the trial, but I asked her to put in the methods. When the trial was completed and the results came out, the conclusion was that the patients that ICD occurred had benefit had to be in the people who had no major systemic disease curtailing their life expectancy. So then when I asked for this analysis, they said, we never did this analysis. We didn't want to do that, which was never in the statistical methods. They forgot to put it in the methodology. So we actually went back to the minutes of the NIH meeting. And luckily for me, the branch director was a CAT guy. And he said, you must do this analysis. And that's how, in a backwards way, you got your ejection fraction analysis, and everybody was stunned that it was the low EF group that had benefits. I mean, people in Europe said it's a waste of money putting in an ICD in somebody with low EF. So just a little digression, but important, I think, for that point.
Very interesting. These are great comments. So, Dr. Saksena, you just briefly touched on some pathophysiologic pathway that could possibly, link obesity and AFib. So do you think this mostly boils down to inflammation?
So I think that these different phenotypes of heart failure, which are also phenotypes for risk of atrial fibrillation, work through the mechanism of inflammatory mechanism, systemic inflammation. There is a genetic predisposition involved here for some of the subcellular mechanisms. And all of this combined with the microvascular dysfunction that comes with the systemic inflammation in the tissues, the atrium, ventricle, and other tissues, leads to the development of microvascular and cellular matrix changes, collagen deposition, inflammatory markers like TNF go up, and interleukins and cytokines, etc. And you end up with the diastolic dysfunction and a substrate for electrical reentry or triggered activity from all of these mechanisms. So it's a very coordinating hypotheses for both AF and heart failure and the different phenotypes.
Okay, very nice. Dr. Sundaram, I just would like to come back to something that you briefly mentioned regarding how electrophysiologists should actually approach prescription for GLP-1 receptor agonists. So they are still underutilized in cardiovascular practice, partly also due to their cost and access. So based on the findings of this study, do you believe that electrophysiologists should take a more active role in initiating or advocating for GLP-1 receptor agonists?
So I do think that cardiologists and the individual specialties within cardiology, so both heart failure, my field, electrophysiology, and general cardiologists, we should have an active role in prescribing GLP-1 receptor agonists because we know that it's a cardiovascular drug as much as it's an anti-obesity medication or diabetic medication. But the thing comes from the access to medications. That's where we actually have the issue. It's the access to medication is quite rationalized related to many reasons. And it's something which stems from that. But let's assume there is no issues with access to medications. It is high time that we use a GLP-1 receptor agonist to modify cardiovascular outcomes. And in this context is about in those patients with atrial fibrillation, at least to start with among those patients who've been referred for ablation with a body mass index of 30, should actually be absolutely considered or even prescribed GLP-1 receptor agonists using obesity as an indication. You can start with the context of all those patients who are referred to the ablation and then move on and expand it in the practice as the access to medication increases.
So I'd like to just make two comments. I think that the access to medication issue is now being actively reviewed in the United States.
Yeah.
Which is a very good step forward. And the more evidence that can be compiled that reduction of cardiovascular risk is good for the healthcare economy will possibly improve the access issue. The other comment that relates to prescribing these agents, and I think very important to have a cardiometabolic expert involved working with electrophysiology to manage these drugs well. And we have to be educated on how to manage these drugs properly and what to care about. I had the privilege of working for the man who, as a student, who discovered the hypothalamic satiety and hunger centers. And one of the things that concerns me, obviously, is that the effects are very widespread of these agents. And we are hopefully looking at more specific agents that come as time goes on. We don't know all the effects of these agents. So it's very important to work with people with experience.
So, Dr. Saksena, I think Dr. Sundaram touched on this, like the challenges of future randomized controlled trial. In your opinion, what would the randomized controlled trial look like in this aspect, and what would be the key inclusion criteria and endpoints and challenges to overcome in this trial?
To do a randomized controlled trial without an active treatment arm, as he pointed out, is really difficult in today's environment. And the other is that to do a long-term mortality trial for a upstream therapy may involve much longer follow-up. And I give the example of the recently published PRAG-25 trial, where it was hoped that in 12 months you will see the benefits of lifestyle modification and antiarrhythmic drugs without a GLP-1 drug. And I think that's really kind of optimistic. And so I think that the way this will have to work is that you have to have a good surrogate endpoint for mortality in AF trial. And the biggest mistake we've made, and we are guilty of it in the firm, was not including a heart failure endpoint. Well, heart failure is the intermediate step to mortality in AF. So a heart failure endpoint is a good, strong endpoint for an AF trial, which is not a usual thing that people say. They look at time to AF recurrence, but I really don't care about 31 seconds of AF for an ECG recording. So that, I think, has to be the endpoint. There are a number of heart failure therapies available. So in the active treatment arm, you can use those without a GLP-1 agent in that arm, without running into major ethical issues into these trials. The hurdles will be that the ubiquitous use of GLP-1 drugs will make it a little more difficult, but I think we still have a window of opportunity at this time. So, I advised Cabana actually to have a heart failure endpoint, which they didn't, but now they see the interest in heart failure endpoint. So I think that's the way we should do an AF trial with some heart failure therapies outlined in the comparator arm and the addition of an anti-obesity regimen on the other side.
Dr. Sundaram, any additional comments?
Yeah, so pretty much Dr. Saksena mentioned all of it. So the only other group where you could study, as I mentioned earlier, was in the group with a body mass index who don't fit into the criteria of obesity, with evidence of visceral adiposity, which we are very good at quantifying now, and to look at what would be the role of metabolic modulation with GLP-1 in the group in patients with AF. In the heart failure, as Dr. Saksena pointed out, it's of extreme interest to us in the heart failure world. One in HFpEF, which we know in this thing, where we looked at heart failure outcomes and we presented a late breaker at the ESC HFA. So it's under consideration now for it's getting reviewed. But the group where we are even more worried is a HFrEF group. So where we are worried with GLP-1 because of the previous two trials, LIVE and FIGHT, showing increased mortality at ventricular arrhythmias with GLP-1 with HFrEF. So we literally have trials with GLP-1 on everything except HFrEF. The reason is everyone is worried about the increased risk. So we don't have in the HFrEF space. That's one area where in the heart failure world, especially with more symptomatic HFrEF, we don't know. I'm not talking about this efficacy from the safety standpoint.
I was suggesting that we use the development of heart failure, emergency heart failure, as an endpoint. And I think I wouldn't suggest doing this in the AF.
Yeah, it's a development. Yeah, I get development of heart failure is a very clinically relevant endpoint, as you pointed out, a new way of looking different at what you pointed out in AF trials as surrogate.
Perfect. Dr. Sundaram, Dr. Saksena, thank you so much for sharing your insights. Transform AF offers a compelling signal that metabolic modulation, especially through GLP-1 receptor agonists, may have meaningful cardiovascular benefits in AFib. And while we're still awaiting randomized data, your study definitely opens the door for guideline evolution and broader therapeutic thinking. And to our listeners, this is a conversation worth keeping on your radar. Could we soon be treating AF with more than just rhythm and rate? Thank you very much.
Thanks so much for tuning into this Cardio Nerds episode. I'm Dan Amender. You can find all the show notes and linked references on the episode page. We invite you to join us in our effort to democratize cardiovascular education, bringing high-quality, engaging content to learners everywhere. You can help us by subscribing, leaving a review, and sharing this episode with your friends and colleagues. Your support fuels everything we do here at Cardio Nerds. And just a quick reminder, this podcast is not intended for medical advice. The views expressed on the show and site are our own and don't necessarily reflect the views of our institutions or employers. All Cardio Nerds content is independently planned, produced, and reviewed by our team. Stay tuned for more great conversations and exciting episodes. And now, my friends, it's time to make like an S2 and split.